trying to coach a team through all kinds of creative strategies to get their client privacy for the therapy session. I was like, okay, really? You're wondering why these kids don't tell you anything? People wandering in and out of the room, I mean, what are you talking about? So we had to spend a lot of time on, creative, humorous ways to put up big signs on the door as to whether you could enter the room or not, and took most of an hour of consultation, but I just thought, this is just critical. But the other thing is that these kind of patients who are very dysregulated, very impulsive, very often escalate in their communications, will get you out of balance. You either become extremely demanding of them to change, or you sort of give up on them and sort of treat them as fragile, and sort of pat them on their head through the session and sort of start doing essentially what we often describe in DBT as palliative care, right? You've essentially become a sort of hospice for them, rather than, actually trying to change their situation. So that's a big part of DBT. Then we get to quality of life interfering behaviors, and this is really where you're looking like any other behavior therapy. So the third highest target is anything that's directly impacting their quality of life to help get them a life worth living. So axis 1 and 2 disorders, substance abuse, life stressors, basic needs, legal problems, whatever's going on. And this makes us look like really any other CBT intervention. What we generally do is treat the most severe first, unless we think we can get a small win, and we go for the more changeable first, right? If I've got someone with panic, where I actually think some breathing training and some other basic things are going to really turn it around, I'll just go after it because we can get it done and we both get a win, and that increases the therapy alliance, and also everybody's a little less distressed if they're less distressed, and so is the world less distressed if they're not panicking all the time. And then we focus on increasing skills, and in DBT we break that into acquisition, which is them picking up the skill in the first place, strengthening, which is making sure that gets higher in their response hierarchy. In other words, this behavior is going to pop out instead of the old impulsive behavior, and that it obviously generalizes. Okay, so that's targeting. So that's a really big part of DBT. Another really big part of DBT is emotion focus and the chain analysis. But bottom line, if it's not pervasive emotion dysregulation, meaning shows up in most situations, shows up over time, sort of problematic everywhere, then you may not need DBT for it. And basically the etiology is that in DBT we think of the person as being born or becoming biologically predisposed to frequent and intense emotion. So that's either a temperament issue, the way that they're born, or often traumatic events will cause an increase in that sensitivity, reactivity. That their tasks in life are complicated by this arousal, so it's just much harder to function in life if you are highly, highly emotionally aroused. That the environment may be increasing your negative arousal, so if you're getting beat up at home or neglected at home or bullied at school, this is not exactly decreasing your arousal. The environment fails to help to manage the arousal, so that you're not in a family or in a living situation that teaches you how to cope with this, and you get this pervasive emotion dysregulation. So this is sort of the idea of how BPD develops, but I think it's pretty generalizable to a lot of other clinical populations.
Kate, with that the second to last environment fails to help manage arousal, what about the individual? I mean, are there individuals, how come it's not individual and environment fails to manage arousal? Because there are some people that...
Oh, well at this point I'm still thinking in sort of etiology. I'm thinking when they're 3, 4, 5 years old and I'm not holding them to too much of a standard.
Got it. No problem.
But like, I'm just watching my nephew, just coming home, I've been watching my nephew on Friday afternoons, and he's 6 months now, and coming from where I work to watching this child, it's really surreal to sort of come from moving from people who've just been essentially broken by their environment. And then, we've got more adults taking care of this one, the first grandchild of the family that you could ever imagine. So we are a village raising a child. So it's just, you can really see the difference. So because of this emotion focus, what we really think in DBT is you've got to make sure that your assessment matches the time frame of the problem. So what's the time frame of an emotion? Go ahead. 10, 15 minutes, right? So that the problem of an emotion is a very short window. So we're radical behavioral therapy, we use functional analysis like every other radical behavioral therapy, but what we're really focused on is a window that's a very, very short period of time. And so what we use is what we call the chain analysis, which is a specific version of a functional analysis that is looking moment by moment over a fairly short window of time. And the idea is that what you're trying to figure out is you've got this problem behavior, and you've got to figure out what made the person vulnerable to it. So that might be ongoing factors. What was the prompting event, the key issue in the environment that sort of was necessary for the problem behavior to occur? What are the different emotions, thoughts, physical sensations, urges, actions, and events that took place between the prompting event and the problem behavior that made that problem behavior inevitable? And then what short and long-term consequences are occurring after it that makes it inevitable it will happen again, right? So the idea is that what we're going to try to do is we're going to fix this chain, right? So I'm just going to kind of run you through what I normally do much slower than this, but just to give you kind of the general idea. So the idea in DBT is we're just linking treatment to these links in the chain. So you could prevent vulnerability and you wouldn't have the problem behavior, right? So you could improve their sleep, you could decrease their physical illness, reduce background stressors, improve their interpersonal skills. There's lots of things you could do to get rid of a vulnerability factor, right? Then the behavior wouldn't occur. You could prevent the prompting event. Sometimes that's feasible. If it's an issue of violent partner, problematic work hours, there might be something you can change. But in general, we don't like to do cue avoidance in DBT or cue removal in DBT. We want people to deal with the cues they have. So usually, if you remove a cue, it actually makes it worse. But sometimes, and if if a kid's being beat up, you probably want to take care of that cue. I don't think they have to learn to cope with that. You might want to add skills. So in DBT, we have skills that are specifically designed to decrease particular behaviors. So there's this whole kind of acting without thinking, what we in DBT call mindless behavior, or acting on emotion mind, just your emotions push and you follow and it's over. And mindfulness skills, which are core skills in DBT, treat that. We have interpersonal skills with the goal of treating the behaviors that trigger all the conflict and strife. So if instead of cue removal, what we want to do is teach them the skills to deal interpersonally so in the future that cue does not occur again. So doing things like screaming at your mother results in things like mother screaming at you. And if mother screaming at you and threatening to throw you out of the house is what's triggering the problem, we could avoid that. But instead of telling mom, stop screaming at the kid, we tell the kid, start using your skills with mom so mom doesn't scream at you. Okay?
Hey Kate, are each of these skills, like that you have in green, would that be an entire session?
No, it'd be an entire 8 weeks.
Each skill?
Each category. So, well, mindfulness is 2 weeks worth of skills.
That's more what I mean.
Yeah.
Okay.
Interpersonal, each of the others, well, interpersonal skills is, well, they're each, about 6 weeks worth of skills training.
Okay, so a little more than
normal.
a session or a group session and an individual session, a little more than one.
To get
per
through this
skill.
whole cycle in a standard DBT model is 24 weeks. To teach everything. This takes 24 weeks. So there's a lot of skills. Each of these categories has a lot of skills in them. And that's why for shorter treatments you have to pick and choose.
Right.
So like Alec Miller's version of 16-week DBT, he doesn't teach every skill. He's been selective as to what he picks. So you have to make decisions. That's part of why I'm saying if you want to decide if you're doing comprehensive DBT and you're going to teach all of this, or integrated DBT where you're going to teach part of this. And that's part of why I wanted to kind of clarify that.
The selected is tailored to the client through the chain analysis?
No, I wouldn't, well, I do that in individual therapy, but what I'm talking about more is like how you'd want to set your program up, right? So if I had a program for MR kids where there's a subset of them who are emotionally dysregulated and they're causing problems within this mental retardation program, there are skills I would teach and there's skills I'd probably let go. That I don't, like some of the skills with interpersonal skills about being able to socially judge when to act and when not to act. I'm not sure they would totally get those social distinctions, and so I don't know that I'd teach it. So I'm thinking more in terms of like the population you're trying to treat.